Thank you very much. I'm very grateful for Catherine de Vries for inviting me here, and it's a great privilege to speak to you. Essential surgery, what's it all about? I feel I am qualified to speak on this subject, having worked in Africa, in Zimbabwe, Tanzania, and Malawi, and South Africa for 21 years. Now, as of course everybody knows, there's an immense increase in the interest of surgery in the developing world in the literature, and there's a sort of explosion of articles about this. And as we've heard, it was previously thought to be an expensive luxury, and that has been clearly demonstrated to be cost-effective by whatever methods you try and use. Now, basically, we've used terms like global surgery, humanitarian surgery, without really knowing and defining what they are. First of all, I'd just like to give some sort of models of humanitarian surgical care that exist. The first is the sort of intervention characterized by Catherine Hamlin, who I'm sure many of you will know of, who supported and initiated the psychovaginal fistula repair in a hospital in Addis Ababa that's dedicated to this type of intervention. So this is the sort of group of individuals, or a single individual, supported often by the state or by home country, doing a specific job in a specific place, often for quite long term. The second model is the long-term assistance of a mission hospital or a local-based institution. The picture on the right is of the Kantabopa Hospital in Phnom Penh in Cambodia, which is hugely supported by the Swiss government to the tune of millions of francs per year. And the small mission hospital in southern Zimbabwe, supported by the Lutherans in Sweden. Clearly, the one on the right can deal with complex issues, complex problems, whereas the one on the top left, less so. The third model is the model of short-term support, typical of individuals and groups with specific pathologies in mind, for example, hernia, cleft lip, and cataract, and so forth. That often means repeated visits, sometimes over a longish period of time, but their intervention is usually transient. This type of model also includes disaster relief missions. And the fourth type is flying out special cases for high technology surgery, things that are really far too complicated and difficult to deal with in country. This is very popular, of course, with the media. Now, all these models that I've described have advantages and pitfalls, obviously, but none of them can deliver surgery systematically to the disadvantaged. And we've got to remember that. Now, it's important to remember what sort of situations are we dealing with. It's important to understand the reality of the situation in most low-income, low-resource, and low-technology centers. It means that programs that rely on high-technology equipment are unlikely to be beneficial for the majority, at least in the short term. And this means that some old-fashioned methods and techniques may actually be more appropriate than modern techniques. We've got to understand also that there's a high volume of surgery that needs to be done, and there's a very ad hoc workload. Things are not planned most of the time, and well-meaning suggestions and schemes are going to flounder if there's no real understanding of this on the ground. And it means that there's no real leeway in a poorly functioning setup for help from outside, which interrupts the current necessary activity. We've often assumed previously that surgery that has been done in the developing world is going to help people in the low-income countries if we just simply follow and do the same sort of thing. This notion ignores the huge problems that we already have in the West of delivering surgery, spiraling costs, hyper-specialization, unequal coverage for different sectors of the population, and so forth. And it's the assumption that the lower middle income countries, the situation there is the same sort of situation that we had in the developed countries 2 or so generations back. And this is just simply not true. So we've got to get rid of these presumptions and presuppositions, as well, of course, as abolishing a paternalistic arrogance that what we do must be best. And most importantly, we must remember that basic resources does not mean bad practice or suboptimal care. Now, the need for surgery is self-evident. It may seem so to us, and I'm sure we're all converted, but it's not to the health planners. So, as we've learned already, we've also got to be political lobbyists. Now, we've already heard about the estimated need for surgery, but it's really quite phenomenal how great the discrepancy is. Only a fraction of those seriously injured get any type of surgical care at all. And of those people who need an emergency laparotomy, only 1 out of 50 gets it done. That means in this room, if everybody had to have a laparotomy, probably only 2 would actually get it done. And what happens to the rest of you? You're all dead, bar perhaps for 1 or 2. Only about 1 in 10 people who need a hernia repair done get it done. Now, the operating facilities in most district hospitals are basic. As I've said, this does not mean that the surgery that is done there is suboptimal. It has to be appropriate. Most surveys of surgery in low-income countries portray a uniform situation, despite climate, social conditions, population density, cultural traditions, and so on. So the situation in Benin is much like in Balochistan or in Borneo. The point is, many, many people who need surgery simply can't get it. And the basic features are a lack of financial investment in infrastructure and the supply of material that is often not related to need, poor maintenance of equipment, and that much useful technology lies idle, and remuneration is often inadequate. I worked in Zimbabwe for most of my time, where the inflation reached a staggering 230 million% per annum. Now, there's been economists here, and I don't know how to work that out, and certainly most people who lived there didn't know how to work it out. The other feature of most hospitals is of poor record keeping, both administrative and medical. And one of the unfortunate features is the plethora of unwanted and inappropriate donations. Some centers, however, are beacons of hope. For example, this children's ward with clean, washable floor, motivated staff with appropriate roles. And a local population does need confidence in their own medical system. You can check this when you ask whether the politicians go elsewhere for their medical treatment or not. If they do, they have no confidence in their own system. However, as I mentioned, even in the poor centers, good work can be done. Now, we've heard this, we know the facts. Less surgery is now being done in district hospitals than in the 1970s. Of the 3.5% of surgery that is done globally, that is done in the poorest third, what is done is mainly done in the cities. And in the government hospitals, this is necessarily mainly emergency work. In the private hospitals, no emergency or trauma work is usually done because it is not remunerative. Now, our famous colleague Paul Farmer, professor of medical anthropology at Harvard, has described surgery as the stepchild of global health. But who is it actually being done by, this surgery? Who performs it? And it is actually done by non-specialists, non-consultants, and often non-doctors. They are working unsupervised, frequently grossly overworked, doubling up as administrators, finance managers, politicians, and often having to do a second job simply because they haven't got enough pay to live on, and so may not readily be available for emergencies. They are working when basic resources are often lacking, where there's no blood for transfusion, often no IV fluids, no antibiotics, and patients' relatives often have to go out and buy these. So organization is haphazard. Operations are delayed till everything required is materialized, and of course by then the patient has deteriorated. A typical surgical workload in a functioning center attempting to deal with current surgical needs is like as demonstrated on the table. There is a huge proportion of emergency surgery, of which between 60 and 80% is obstetrics and gynecology. We cannot exclude obstetrics if we want to talk about surgery in low-income countries. The remainder is trauma and sepsis, and elective surgery only occupies about 5% of the total. Now, after obstetrics and gynecology, I've said, there's trauma. Trauma, of course, by its very nature, is a surgical problem. And almost all of it is because of poor regulation of road traffic. As you can see, the truck there is a disaster awaiting to happen. Now, if we look at the impact of road accident trauma in Africa, we can see that there's a staggering 3,000 deaths per 100,000 vehicles on the road per year. The wooden spoon currently goes to Togo at 10,000. In other words, 1 in 10 of every vehicle causes a death each year. Now we compare this 3,000 deaths per 100,000 vehicles with 12 in Europe and the United States. There's an astounding mortality of 350 per year per million vehicles, and Eritrea is the worst on that score. This compares with about 25 in Europe. So in other words, it's more than 10 times as dangerous being in a car in Africa. And most of these deaths are not because of the severity of injury, but because of the lack of means and capabilities available. Now we've got to remember something about the population, the demographics, particularly in Africa. It's of vital importance to the future, to the politics and the economy of Africa, obviously, but it also impacts on surgery. 65% of the total population of Africa currently is less than 35 years old. Each year, 10 million youth arrive on the labor market in Africa, and by 2030, 60% of all urban dwellers will be under 18 years old. This means those people who are going to get trauma are young, and with just a little help, airway management, hemostasis, and fluid replacement, they will survive. Now, I think we all realize that surgery needs to be done, but how is it going to be made available to those who don't get it? We need a revolution. The picture shows the classical picture of the French Revolution, a precursor to the American. We need a radical reevaluation of how surgical care is delivered. My question is, where is the fairy godmother coming to the rescue of the neglected stepchild? We're going to have no success with a haphazard bit of aid here and there, and no success by backing up systems that just no longer function, if they ever functioned properly before. How is surgery going to be made available to the poor? And more importantly, who is going to do it? We've seen this slide also before. The WHO principally demonstrated how low-cost improvements have substantial benefit. Now, the WHO's initiative for emergency and essential care is a good attempt, but is it falling on deaf ears? And what is the definition of essential care and essential surgery? This is what our group has been looking at, and we have made a number of definitions. We've defined essential surgery as simple, emergency, and cost-effective measures which save lives or prevent lifelong disability and repair life-threatening pathology. I'll repeat that. Simple, emergency, and cost-effective measures which save lives or prevent lifelong disability or repair life-threatening pathology. So here is the list. Now, most of these interventions are not terribly difficult. This idea is not new, and I claim no originality. Professor Eldred Parry, the doyen of tropical medicine in London, put forward this concept in 1999 in a paper in Trauma Quarterly. And the proposition is that those surgeries will deal with 80 to 90% of the surgical need. Now, our group is to push forward this concept. The argument that 12 to 15 basic surgical procedures will deal adequately with 85 to 90% of the surgical need is not something that is got an evidence base as you might want in journalistic terms and in terms of surveys and so forth. But it is the common experience of those like myself who spent their professional life in Africa. Now, this is the surgery that needs to be done, and of course, broadly speaking, is not being done. Training, therefore, in my view, must concentrate initially solely on these interventions. Now, I've been spooked. Many of my illustrations have already appeared here. This, of course, is all about Semmelweis. Now, the surgical establishment, as again we've heard already, of his day refused to recognize Semmelweis's advice on staff washing their hands. And despite the fact that his patients survived and those of his colleagues did not, it took years for the practice of hand washing to be accepted. Likewise, many of the traditions of the time need to be set aside. Those subsumed by the developing world, nurtured by us as well as our own. The tradition I'm talking about is founded on the concept that we must train omniscient doctors and likewise omniscient surgeons. Semmelweis ended up, as we've heard, in the psychiatric hospital. I hope I won't myself. Surgical training has been based for generations on the concept of building up a very general knowledge base. But the idea of an all-performing, all-competent generalist surgeon has long gone in developed countries and indeed in the developing countries. The specialist in the West forgets all the subjects he's no longer concerned with, palming them off to another colleague. Now, the present situation in developing countries is that medical students, as indeed worldwide, spend many years learning the general basis of medicine. Trainee surgeons then spend more years learning general surgical practice, and then even more years following a specialty interest, inevitably forgetting what they'd learned 5 or more years before. Now, this scheme of things takes 14 to 16 years to train a surgeon and is incredibly expensive. Following the Western academic colleges, many African surgical colleges also encourage specialization and promote this fantastic system of training. But can we expect enough specialized surgeons in lower middle income countries when there are hardly enough surgeons at all? And who will do the basic general surgery? And how can we promote general surgery when we can't even define it in our own countries? Who indeed will deliver surgical care to the poor? A study done in Sierra Leone, which is not a worst-case scenario, showed that 19 hospitals were functional, 2 referral, 3 provincial, 12 district, 1 private, and 1 charity. 20 qualified surgeons were in the country, all but one of them was significantly over 50 years of age. 6 surgeons were in private practice, and 4 Chinese were working in hospitals with no gloves and no oxygen. So that means perhaps 10 surgeons were currently in post. Now, WHO estimate was that this country needs 80 to 100 surgeons at minimum. Where will these 70 to 90 surgeons come from? If it takes 10 to 15 years to train a surgeon, it is totally futile to expect enough surgeons in Sierra Leone in 20 or even 50 years, because mainly of migration. So what do we do now? I come back to a previous slide. These are the guys who are doing the surgery, the clinical officers, who are there in their home areas doing what they can as best they know how. The problem is that these clinical officers are often working unsupervised, unmentored, and certainly uncertified. In many, many places, there is no one else who will do the surgery, and if these clinical officers don't do it, no one will do it. So let's not look at the negative side, but at the positive. Since much surgery is already done on an ad hoc basis, unremarked and unrewarded, we must reverse this situation. Indeed, clinical results have been shown to be as good when done by trained clinical officers, if not better, than when performed by so-called trained doctors who have not actually had any practical surgical training. Non-surgeons and non-doctors, like clinical officers, showing aptitude and keenness must be motivated. And to nurture such essential surgeons, local expertise has to be tapped, supported, and encouraged. This has been termed task shifting, but I prefer the term task sharing because local surgeons and supporting institutions are needed to mentor these trainees. Local practitioners should be encouraged for training in their chosen field, for example, wound care, laparotomy, caesarean section, and so forth. No one trainee would be expected to become proficient in all areas. And this training could be done on a modular basis, 3 months to a year for each module, depending on its complexity. We in ICES are in the process of drawing up a simple curriculum and courses for essential surgery, and it should be given its essential recognition. The ISS, International Surgical Society Academy, is willing to certify such training, and it would be great if other institutions come on board to validate such training. It is in this way that the essential surgical training can be fast-tracked. Support of local colleges and supporting institutions is therefore mandatory. It's been shown that these trained and certified essential surgeons stay in place, occupy a pivotal role locally, and are well-liked. It is they who will provide the backbone to surgical care for the poor. We know of twinning of institutions, which is often seen as a win-win situation. There's an enormous amount of goodwill generated, and defined projects are initiated. It is this that we must encourage in terms of surgical training. And in closing, ladies and gentlemen, I'd just like to talk of two heroes. Hamilton Narkey left school at the age of 14. He hitchhiked from his home in Transkei to Cape Town to find work to feed his family. And he was employed as a gardener at the animal laboratories attached to the University of Cape Town in South Africa. In 1954, he was asked to hold down a giraffe which was being dissected to find out why it didn't faint when stooping down to drink. He was then promoted to clean the animal cages, then to hold down the animals, finally to anesthetize them, and then to operate on them himself. Quoted as saying, "I stole with my eyes," he ultimately became the best and fastest dissector in the laboratory, teaching many future surgeons. He was involved with Christian Barnard at the first cardiac transplant operation, and Christian Barnard himself called him the deftest wielder of the scalpel in Cape Town and an expert in liver transplantation in his own right. He retired officially, still a gardener, in 1991 and has since passed away. Mamitu Gashe, at the age of 15, illiterate, arrived at the Fistula Hospital in Addis Ababa. Surgically cured of her fistula, she had nowhere to go, and so was employed in making beds. She then helped to clean in the OR for 2 years, then to assist cutting sutures, then to assist at operations, and eventually to perform the operations herself. Now a teacher of vesicovaginal fistula repair, she was awarded a well-deserved honorary FRCS. She never went to school. Ladies and gentlemen, if these two, without a degree, without formal medical education, without high school, or in the case of Miss Gashi, without primary education even, can achieve surgical greatness, let us take up the challenge and train clinical officers as essential surgeons. This must be the goal and aim of true humanitarian surgery. Thank you.